Hello, my name is Lynn. Today I will be talking about amputations. Before I begin, I would like to make a few statements about my source. While this is a journal review of one source, the article I chose is actually an analysis of studies that were published between 1970 and 2006. So even if I'm citing Robert Galey and his colleagues, if you're interested in the original studies that I will mention, you can find that in the reference page of my source at the end of this presentation. Some topics that will be addressed in this presentation are as follows: the reasons that necessitate amputation, secondary conditions associated with amputation and usage of prosthetics, as well as things we can do as clinicians to address those concerns. I know we have yet to have an in-depth discussion about amputations in class. However, you'll notice that the secondary conditions are familiar topics that we have already covered. Most of the subjects who participated in the researches regarding amputation are military veterans in their late 40s and up who were in their mid-20s when they were amputated. While some of you may not plan on catering to the veteran population, about 82% of amputations are linked to vascular disease, usually secondary to diabetes, a health condition that we have spoken about and know to be very common amongst the general population. About 16% are trauma-related, which is not restricted to the veteran population. Examples of trauma include, but is not limited to, car accidents and severe burns. And less than 1% of amputations are due to some kind of congenital deficiency or tumor. One of the first concerns we will talk about is osteoarthritis. We know that osteoarthritis is common in the older adult population. As we age, our bodies lose the ability to manage the delicate balance between bone formation and bone resorption, especially when we favor more of a sedentary lifestyle. Research shows that there is a higher incidence of osteoarthritis of the knees and hips in people with amputations than without. When a moving bone is optimally aligned within its joint space, compressive forces are distributed in such a way that minimizes the wear and tear of the articular surfaces. For amputees, one of the reasons for malalignment is improper fit or use of the prosthesis, which can lead to compensatory movements or positions in order to alleviate the discomfort, but places more stress on the intact limb. There was a study performed in the early 90s by Lemaire and Fisher who measured knee joint reaction forces via force plates. There were a total of 24 participants, half of which were transtibial amputees and the other half non-amputees. They found that the amputee group exhibited 12% more vertical knee joint reaction forces in the intact limb than the control group. They attributed the results to the significantly shorter stride length and slower walking speed. The decrease of weight bearing on the residual limb can over time lead to osteopenia. During the 70s, Hungerford and Cocken did a study examining the radiographs of 117 amputees, either transtibial or transfemoral. They found that 88% of the subjects showed signs of osteoporosis of the residual limb. There were more studies done in the 80s and 90s that supported these findings. Researchers suggest that osteopenia was more common in subjects due to the disuse of the residual limb. That is not to say that it is always on the part of the patient. As I was looking for the journal for this assignment, I read that certain prosthetics are more adept at distributing forces that mimic that of walk-in and non-amputees. However, that is beyond the scope of this conversation. The key takeaway is that with osteopenia, osteoporosis, amputees are at a higher risk of fall-related fractures. Unfortunately, most amputees are not diagnosed with osteopenia, osteoporosis until post-fracture. Back pain is a common complaint amongst the general population. In the late 70s, Burke and his colleagues were the first to perform radiographic studies in people with lower limb amputation. They found that 18 of the 42 participants had scoliosis, and 32 of them showed degenerative changes in the lumbar spine. Authors of different sources suggest possible causes to include the prosthetic fit alignment, as mentioned earlier, abnormal posture such as the compensatory anterior pelvic tilt, leg length discrepancy, which can cause lateral tilting of the pelvis as well as spinal compensations to remain upright, as well as general deconditioning. But as of the time of publication of this article, it is unclear whether these factors contribute to or exacerbate back pain in a population already predisposed to it. So as clinicians, what can we do to minimize the risks of these secondary conditions? One of the major tasks for the rehabilitation of patients with amputations is to normalize their gait patterns, which sounds very general, so we'll break it down further. In order for patients to spend more time on their residual limb, they need to strengthen the remaining musculature, which may have weakened and been subjected to contracture during the recovery phase following amputation. One way to minimize muscular atrophy during that time, so long as post-surgical precautions are followed, is isometric contractions and e-stim. When walking, we plant one foot and lift the other, so the residual limb has to be strong enough to support the weight of the body while the intact limb is mid-stride. That also includes a sense of balance, so the patient will have to learn to balance on just their residual limb. In the previous slide, I mentioned a compensatory anterior pelvic tilt that may cause low back pain. Thus, it is also important to educate the patient to be cognizant of the positioning of their pelvis as they move. We can also include core stabilizing exercises, which improves posture and reduces stress on the lumbar spine. These very same interventions are used for the rehabilitation of such conditions as total knee or hip replacement, post-stroke, as well as preventive care for the geriatric population. Even though the diagnosis differs, we are addressing the same concerns: gait, balance, strength, just to name a few. Note that most of the studies that were analyzed for this article were performed on military veterans who were young, healthy, and active males at the time of their amputation. Most of what you will see and treat are the population on the opposite spectrum. Therefore, it is crucial to encourage patients to adopt or continue with an active lifestyle to prevent the secondary physical conditions mentioned in this presentation. It is also important that patients develop a long-term relationship with their prosthetists to ensure proper fit and care of their prosthetic limb. That concludes this presentation. Just to recap what we have discussed today, we learned that the number one cause of amputation is due to vascular disease, secondary to diabetes. The common concerns amongst our amputee population is osteoarthritis, osteopenia, osteoporosis, and back pain. A large component of rehabilitation should be spent normalizing their gait pattern as much as possible, including strength and balance. Please note that these studies focus primarily on the physical secondary conditions. There is an emotional psychological component that is beyond the scope of this presentation, yet should be taken under consideration when treating patients with amputations. Thank you so much for your time today.